În continuare o să-l invit alături de noi pe domnul dr. Hossein Sadeghi, care este directorul centrului de fibroză chistică Sue and John L. Weinberg din New York, specialist în pneumologie pediatrică, pediatrie și medicina somnului. Domnul dr. Hossein Sadeghi, în aplauzele tuturor, vă rugăm.
Good morning, everyone. I would like to thank the organizers for bringing all of us together. This is an impressive job that they have accomplished, bringing so many colleagues across the country in Romania and internationally. I just want to dedicate the whole conference not only to Patrick, but also to, I'm probably going to kill this name, Mietzel, Vladimir, Philip, Bianca, and Danielle. But also to Wanda, the mother who spoke, and all the mothers who spoke on their behalf. This is a chronic illness, and it needs a lot of team effort. So thank you for organizing this. So we are going to, the objective of my talk is to review progress in diagnosis and treatment of cystic fibrosis, and also discuss means to make this progress equitable across the globe. Cystic fibrosis is a success story in the United States. If you look in 1938, I don't know if you have a pointer. This was the original article by Dr. Dorothy Anderson, who was a pathologist at Columbia University, the same institution that I'm honored to serve. So in 1938, the life expectancy was less than 6 months. Fast forward less than a century. In 2022, life expectancy is 53 years of age. And today, we are expecting the kids with CF who are born, hopefully to have a normal life expectancy. So what are some of the contributing factors to this success? Understanding the CF pathophysiology, diagnostic testing, we need to diagnose CF before we are able to treat it, specialized CF care centers, gene discovery, symptom-modifying treatments, and finally, treatments targeting the genetic defect. So we're going to talk briefly about each one of those. So understanding CF pathophysiology. As you know, CF is an autosomal recessive genetic disease. The gene product is called cystic fibrosis transmembrane regulator protein. It's a chloride channel, it's a bicarbonate channel, and is a regulator of sodium channel. To understand this slide, then you understand the whole pathophysiology. So ignore all the excess. Let's review what happens in the normal situation. You have the DNA in your nucleus. That DNA codes for an mRNA. That mRNA codes for the protein. That's all happens in the nucleus. Then the protein comes out of the nucleus, gets processed in the endoplasmic reticulum, packaged in an organelle called Golgi apparatus. Then it's ready to come to the surface, and that protein on the surface is a chloride channel. So that chloride is passing through that cell surface. Every step of this way, you can have problems and gives rise to the different classes of the CFTR protein. And that's what the whole treatment is all about. So class 1, where there is no protein is made. That example is W1282X, which is common in the Jewish population. Class 2, the protein is made, but it's not fully complete. That's delta F508. So it becomes degraded before it even gets to the cell surface. Class 3, the protein is made, comes to the surface, but the gating is not working properly. So the chloride is not able to pass through. Class 4, the protein comes to the surface, but there is problems with conductance. So the chloride can't be conducted through that channel. Class 5, there is increased degradation. And that's an example of this is 5P. And class 6 is accelerated turnover. Class 3 was the G551D. That was the first variant that the ivacaftor came and was effective. It's common in the Irish population. So loss of the CFTR protein activity is the underlying problem. So in a normal individual, the channel is working. So the chloride passes through and it allows the water to follow the chloride. However, in the CF individual, there are two problems. Either there is reduction in the quantity, as you can see there are no channels on this, or if there is, that channel is not working properly, so the chloride can't pass through. So loss of CFTR protein activity causes impaired chloride ion transport, which leads to fluid and electrolyte imbalance in epithelial cells, such as lungs. So this is exactly what it's showing. This is the mucociliary on top of the cell surface. And these are the chloride channels, and it's working properly. So chloride is passing through. In CF, the channel is not working, so the chloride can't pass through. And because of that, all the secretions are really thick. The mucociliary function is not working. It's like putting tar in your lungs. So this summarizes the whole pathophysiology of CF. You have a defective gene. That defective gene codes for a defective protein. That protein is responsible for chloride and sodium absorption across the cell membrane. Because that's abnormal, the mucus is abnormal. That's a vicious cycle of obstruction, infection, and inflammation. And that gives rise to permanent lung damage. So what are the diagnostic testing? So it was a misconception that CF is only a Caucasian disease. Now as we go across the globe, it's actually present at any age and in any race and ethnicity. How do we diagnose it? You need the appropriate clinical symptoms and signs, plus diagnostic testing that shows that CFTR is not functioning. And what are some of your clinical symptoms? So you can have meconium ileus, that can happen in 15% of infants being born with CF. You have malabsorption, failure to thrive, recurrent respiratory infection if it's later on in their disease, nasal polyps, rectal prolapse, male infertility, and electrolyte depletion. How do you prove proof that there is CFTR dysfunction? Easiest way is the sweat test. There is nasal potential difference as well. But also, if you know the genetic makeup, that combination can give you a clue that it has CFTR malfunction. An easy site to go to is CFTR2, which is compiled by Johns Hopkins. So what are some of the benefits of newborn screening? The sooner you diagnose, the better you can treat. Also, the cost of treatment is reduced in patients who are diagnosed through newborn screening. There's improved long-term health outcomes and evidence of nutritional benefits. We're going to show that later on. There's improved growth, increased life expectancy, and reduced hospitalizations. Infants diagnosed later in the first 2 years of life had airway obstruction at presentation, even if they had no respiratory symptoms or signs. And this never recovered despite the getting appropriate care in the CF center. And parents have the opportunity to make informed choices after the antenatal diagnosis. We had patients, because the younger patient was diagnosed, we do the workup on an older patient, and then we find out that they also have CF. So if they know, they can make appropriate planning if they want to. A large number of newborn screening protocols exist, including measurement of serum immunoreactive trypsin, which is IRT, which is basically a fingerprint, and the CFTR mutation analysis. Each state in the US have their own newborn screening. So we have 50 states, we have 50 newborn screenings. So you can use that as a model, you use that across Europe as well. So screening diagnosis must always be confirmed with the sweat test. And these are some of the cutoffs for sweat test. So normal is less than 30. You have the indeterminate, which is between 30 to 59, and then positive if it's 60 and above. I'm biased, but truly, because it's not because I work in New York, but New York State has one of the best newborn screening. It should be almost a model for every state in the US. California has one similar to New York, but also it should be a model for across the globe. This was the model before 2017. So it used IRT, and then if it was a high IRT, the top 5%, then if they had detected 2 variants or 1 variant, or if it was in the top very high IRT, the 0.1%, then it was referred to the CF centers and for sweat testing. But in 2017, it was changed. So it was IRT, the top 5%, but then if it was detected, there was 1 or 2 variants, or it was very high IRT, if the whole sequence was done, including deletion and duplication. So by the time the infant is referred to us, we know their genetic makeup, and we do the sweat testing. So having a specialized CF center is very important, because you have dedicated individuals who following the guidelines. And this conference is an example of what the CF Foundation in the US did. CF Foundation in the US was developed in 1955 by a handful of families. Who would imagine those handful of families will come up with $1 billion organization, improve the life of CF for everyone and across the globe. And their mission at the time was to assure the development of means to cure and control CF and to improve the quality of life for those with the disease. And they have truly lived up to that mission. And this is the scope of their mission. They have basic research, drug development. The reason Vertex exists today is because of the collaboration between CF Foundation and the Vertex, who was another company who was going broke, and Vertex actually, the CF Foundation partnered with them. Drug development, clinical care, that can be an example for this country. And also people with CF have a voice in the CF Foundation. They are partners with the CF Care Network. We have a family advisory group as part of our care network. And what does that clinical care involve? You have this care center network, patient registry. We need to know how each center in the US is doing. Not only is not to give them awards or punish the centers, but go to the centers who are doing well and learn from those centers And those who are doing poorly, then look at them and say, what can we do to improve those things? Clinical practice guideline, quality improvement. Just Oregon is the size of the Romania, has one center, but their population is only 4 million. New York State, which is where I work, has 19 million, almost the same population as Romania. There are 10 centers in the state of New York. So these are some of the timelines for CF. When it was diagnosed initially, the life expectancy was low. Then the sweat testing was developed. By the way, sweat testing was developed by Dr. Agnes, who was another physician at Columbia University. This was the first center that was created. Still, life expectancy was single digits. And then you had patient registry, but still life expectancy was low. And this was in the 1960s. Then we had to do symptom modifying treatments. But in order to do symptom modifying treatment, we have to understand what CF causes. If you go from head to toe, CF causes sinusitis, pulmonary disease that causes is mortality. All the mortality or majority of cause of death is related to pulmonary causes. 85% of patients with CF have malabsorption, so GI symptoms. So when they drink or eat fat and protein, they don't absorb it. 5% of patients have liver disease. As the patients age, that's before the age of CFTR modulator, they develop the pancreatic disease and endocrine, and that's why from age of 10 we screen for diabetes. 99% of male patients are infertile. That's all going to change as well with the new drugs. And majority of female patients have reduced fertility, but they can get pregnant. And then you have to watch out for hypochloremic metabolic alkalosis. That's why during summertime, when they lose a lot of water and salt, they need to add salt to their diet. And that's one thing I ask parents when the kid come to me, whether it's salty tasting skin and clubbing of fingers and toes. These are some of the fundamentals of CF patient care. They need to follow infection control measures. So 2 patients with CF should not be in the same room. And the reason we put gowns and gloves is not to protect us, is to protect the individual with cystic fibrosis, so we don't transmit one infection from one patient to another. Promote healthy growth and development, address any nutritional deficit, including pancreatic enzymes, and preserve the lung function. How can we preserve the lung function? By chest physical therapy, airway clearance, mucus modulating agents, and antibiotic regimens. These are some of the infection prevention and control directive. So assume all patients with CF have contagious pathogens in the respiratory tract. Educate CF care team, patients and their families regarding infection prevention and control. So patients need to also be their advocates. Even when they come to the Columbia University, I ask the patients to be their own advocate. They shouldn't be waiting in the waiting room. If they do, they're going to tell the MA or the receptionist that I shouldn't be waiting here. They go straight to the pulmonary function lab and they go straight to the exam room. Minimize the potential for contact and droplet transmission in healthcare and other settings. Separate patients with CF from one another for at least 6 feet. That's for outside. Inside, there should be only one patient with CF in each gathering. I'm just touching base on some of the highlights. The treatment for Pseudomonas. Everyone agrees across the globe. Whether you're in UK, Australia, Canada, or America. You have Pseudomonas, everyone agrees. What do you need to do? Prevention of infection. That's the guidelines that we just talked about. As soon as you detect Pseudomonas, which is the intermittent infection, then you try to eradicate. And the eradication with nebulized antibiotics. The oral antibiotics showed there is no value. And then if they develop chronic infection, then chronic suppression with every other month antibiotics. Talking about nutrition. This was the difference between the Canadians in Toronto and the Americans in Boston. Initially people said people with CF have problems absorbing fat. So Toronto didn't change the fat content in the diet of patients with CF. Boston said, okay, let's limit their fat in their diet because they can absorb, they get gassy, they have symptoms, they're irritable. What it showed that nutrition is important. You give nutrition to the patients, they're going to live longer. Versus Boston, which they limit their fat, their survival decreased. And that's another study. Early nutrition impacts later lung function. So if their weight for height is low at 3 years of age, so you can see their lung function at 6 years of age will be low as well. So it's important. Nutrition early in life is going to impact lung function later in life. So these are the initial factors that help the survival for an individual with CF. We had newborn screening, CF registry, we had CF centers, nutrition, pancreatic enzymes, airway clearance, antibiotic regimen. So that's where we were. Then we had the symptom treatments. Life was in the mid-30s. And right now you are in 2000s, when Dr. Daniel was doing the postdoc in New York. So that's when the life expectancy was. So then gene discovery happened in 1989. So this is the evolution of treatments. You had your symptomatic treatments, now we're targeting the gene defect. There are two ways to target it, either by gene therapy or addressing the protein defect. So address the underlying genetic abnormality or restore function to the CFTR protein. So this is what Vertex is doing right now. So we have an oral tablet or drug. There are two targets. You have the potentiators. That was, remember that class 3 on that diagram? This is G51D. So that's increased opening or gating of the CFTR channels. So that was ivacaftor. You gave it, the chloride channels are opening, chloride is passing through. Then you have the correctors. So increase the number and function. So you have the delta I508. These are your lumacaftor, tezacaftor, alexicaftors. So they increase the number, and whatever they increase, they're going to work better. So we went through it. So what the defect they're doing is increased number, and they're making these channels work better. So these are the CF modulators that came up. In 2012, ivacaftor came about, which was a lifesaver for those 4% of individuals who could qualify at that time. Now, ivacaftor is approved for 4 months and older. Then lumacaftor and ivacaftor came about in 2015. That's called Orkambi, and that's for those with homozygous. They have 2 copies of delta I508. and is approved for patients 2 years and older. Then Symdeko, tezacaftor and ivacaftor came about, which we don't use because Trikafta came about. So Trikafta is basically Symdeko. So you have elexacaftor plus the Symdeko. So you have elexacaftor, tezacaftor, ivacaftor. And all you need is 1 copy of Delta I-508. And from June of 2021, it was approved for kids 6 years and older. FDA is reviewing it right now. Hopefully by spring, it will get approved for 2 years and older. So what needs to be checked? Liver enzymes needs to be checked every 3 months for the first year and then annually. And for individuals who are less than 18 years of age, eye exam to rule out posterior cataract. So this is what ivacaftor did. So if you look at the lung function, it's impressive. This is the placebo if they were just taking sugar pill. Within 2 weeks of taking ivacaftor, there was a 10% improvement in lung function, which is impressive. Then Orkambi, again, it's not as impressive as ivacaftor, but it increased the lung function by about 3%. In a normal individual with CF, the lung function drops by about 2% each year. So by taking the Orkambi, that basically blocks that drop. Then you had the ivacaftor with tezacaftor, which is the Symdeko. So this is individuals who had 2 copies of Delta I-508, again about 5% or 4% increase. And if they had only 1 copy of Delta I-508, that's on the right-hand side, then you had about 7 or 8%. Then Trikafta, which is ivacaftor, tezacaftor, elexacaftor came about. So if you have 1 copy, you get about 10% increase, and then in the other individuals, you can have up to 15% increase. But it can be even better than that. We had individuals who their lung function was 30%, went up to 90%. I had an individual I was speaking to last night here. His lung function was 19%, went up to 75%. He needed non-invasive ventilation at night. He doesn't need it anymore. So he's a lifesaver. So this is where we are right now as of 2020. So lung function is in the high 40s in the United States, but it doesn't stop here. So right now, life expectancy for an individual in the US with CF is 53 years of age, which is great. But we have to make this progress equitable across the globe. So it took us 80 years in the US, but it shouldn't take 80 years across the globe. That 80 years can be in 8 years, but you need to follow the same things. You need to have a newborn screening. It's going to convince the health department that they're going to save money. If you approach it that way, I think it makes it easier. Always you have to have a color of financial when you're speaking to an administrator. And then you need to have CF multidisciplinary team. You need to have CF registry. In order to go to your administration and say, Trikafta made a difference, you need to have a registry to show, okay, my life expectancy before was in teens, and now we are all living in our adulthood. You need to have symptom-modifying treatment. I always say that in my talk. When you sign up for marathon, you need to learn how to walk before you sign up for marathon. Everyone wants to skip all the basic treatments and go stand at the finish line in the marathon. So do the basic treatments and then get CFTR modulator therapy. And then this is, you need to know your variants. Hopefully I don't make a mistake where Romania is, but it's right here. So more than 50% of Romanians with CF have at least one delta F508. So that's a good news. So I want to end by saying that story of success continues, whether it's locally, nationally, and globally. And all of you, this conference by itself shows that you're empowered to make the changes. Just do it and make it. Thank you.
Thank you so much. Mulțumim foarte frumos domnului Dr. Hossein Sadeghi. Avem o sesiune de întrebări și răspunsuri. We have a Q&A session. Obviously, you're more than welcome to join us and we'll ask and tell people. Așadar, orice întrebări aveți, vă aducem, vă pregătim un microfon. O rezolvăm acum. Mulțumesc. Puteți folosi calmea.
Thank you very much. It was a very nice presentation about all this history, and we are in the right moment, in the right place to do these changes. So my question is, you have a long experience with newborn screening. What do you mean by very high IRT? I mean, you have a number?
So first of all, you shouldn't have a fixed IRT.
Yes, we just started with
exactly.
Yes.
It should be seasonal variation.
Yes.
And when we say very high IRT, it's the 0.1% for that day.
Okay, thank you.
Alte întrebări?
Sunt profesorul Pop de la Timișoara. I have a question for the professor. Sure. În fapt, un mic comentariu. În primul rând, vă mulțumesc pentru prezentare. În orice patologie cronică și mai ales patologiile cu substrat genetic, partea de consiliere, partea de evaluare psihologică și de susținere este, a zice, echivalentă cu restul de terapiilor. Dar aș vrea să, apropo de modelul pe care l-ați enunțat, modelul biopsicosocial, o particularitate importantă în fibroza chistică este, mai ales în condițiile în care diagnosticul se pune de la naștere, este ca această evaluare să se facă global, adică să cuprindă și pacientul și familia. Și pornind de la aceasta, pentru că este o întâlnire care se dorește de lucru și care se aducă îmbunătățiri, ar trebui cumva susținut la nivel de guvern, la nivel de foruri decizionale, să se modifice un pic spre substanțial schema de personal. Până nu vom avea în spitale sau în ambulatorii psihologi specializați, nu vom face nimic. Deci va fi o pură teorie. Medicul curant nu va avea niciodată timp să evalueze bolnavul, să evalueze părintele la standardele necesare unei astfel de situații. Eu vă mulțumesc pentru prezentare, am fost o atenționare deosebită, dar mai avem mult în acest segment între teorie și practică. Mi-e pare foarte rău că în toți anii ăștia încă nu s-a rezolvat această problemă. Iar pentru domnul profesor, sigur că definiția clasică a fibrozei chistice, cea mai frecventă anomalie autozomală recesivă a populațiilor caucaziene. Într-adevăr, este cea mai frecventă, dar nu că o întâlnim doar la populațiile caucaziene. Sigur, se spune că se consideră în țările cu standard scăzut, incidența scăzută a bolii poate fi legată și de condițiile socio-medicale. Dar și în țările cu standard înalt și, eu știu, mă gândesc la Japonia, de exemplu, într-adevăr, incidența bolii este semnificativ mai mică și dacă ne gândim la evoluția ancestrală a populațiilor, se consideră că fibroza chistică are legătură cu migrația populațiilor de origine feniciană, avem așa o înțelegere a incidenței totuși mai frecvente în populațiile de origine caucaziană. Asta așa frumos ediția. Vă mulțumesc.
Mulțumim și noi. Întrebări nu aveți. Ok.
Sunt absolut de acord. Totdeauna mare problema asta cu numărul de psihologi și că nu avem psihologi în sistemul medical. Specialiști sunt. Și asta creează, de fapt, o problemă de echitate. Cei care au bani își permit să acceseze psihologi în cabinetele particulare. Îmi țin minte și când am început de primele servicii oferite în zona asta pe consiliere genetică, la făcută regii privat. Dar discrepanța, să știți că nu văd între teorie și practică. Este într-o practică cum ar trebui făcută, că știm că funcționează în alte zone și cum o facem din păcate noi. Deci e clar că trebuie să ne punem împreună resursele. Asta este clar. Colegiul medicilor, colegiul psihologilor să cere mai multe resurse. Dacă tot vrem să facem ceva. De unde? Evident din zona autorităților. Dacă vor să asigure și echitate.
Mulțumim frumos. Avem întrebări?
Can I make a comment on that?
Absolutely, please.
So the outcomes is universal. It's even shown, even in resource-rich countries, those who are on state insurance versus on private insurance, or those who have no insurance, there is a difference in outcome. So that's given. And regarding the psychologists, after COVID, there's shortage of psychologists everywhere. So it's just hard to find them everywhere. Regarding physicians, I blame British, they've been everywhere, so you can debate them.
Bună ziua! O întrebare pentru domnul Hossein. Mă numesc Lunguriana, sunt farmacist coordonator la Cultura Popoară. Apreciez enorm ideea cu care ați venit, că tratamentul întotdeauna trebuie început cu lucruri simple și după de abordat tehnicile mai elevate. O întrebare tehnică în sensul ăsta. Ce concentrație recomandați dumneavoastră pentru soluțiile de bicarbonat cu clorură de sodiu în aerosol în tratamentul pacienților cu fibroză chistică? Mulțumesc!
I don't use bicarbonate, so I don't have recommendations for the dosage. So the thing that we used, even the basic stuff, so it's just the airway clearance and then albuterol that we use. Even the hypertonic saline, if the patient is asymptomatic, have no respiratory symptoms, I start the Palmazine around 5 years of age, that's Dornase alpha, and start hypertonic saline. And I try to do the pre and post spirometry just to make sure that there is no bronchoconstrictive effect of hypertonic saline, and then start that at 6 years of age. The initial emphasis is on nutrition. Even the airway clearance, I start them later on. There were Australian studies that showed if you start airway clearance very early, it can lead to aspiration. So we start them later on, like around 3 months or so, 3 or 4 months of age. The bicarbonates, I don't use them, so I'm not going to mislead you.
Ok, thank you, mulțumim. Alte întrebări? Pentru domnul doctor, orice întrebări? Nelămuriri? Clarificări? Ne întâlnim cu dânsul și după pauza de prânz, încă o oră bună, tot într-o sesiune de lucru, dar dacă mai aveți ceva întrebări referitoare la prima parte a prezentării. Văd, să vă rog.
Bună ziua, mulțumesc mult domnilor profesori și străini și români care au venit aici. O completare la ceea ce s-a discutat anterior legat de multidisciplinaritate, de prezența unui psiholog în comisiile multidisciplinare. Cred că până la legislație revine în sarcina managerilor de spitale. Practic, UMF-ul și universitățile trebuie să creeze aceste discuții, aceste echipe multidisciplinare, dar angajarea unui psiholog ține exclusiv de manager. Deci managerul fiecărui spital ar trebui convins să angajeze și un psiholog. Mulțumesc mult!
Nu știu dacă vă ajută ca răspuns doamnei farmacist care a întrebat concentrație. Deci toate studiile făcute cu hypertonic saline sunt făcute cu 6%. Ce este sub 6% poate sau nu poate să fie eficient. Nu sunt studii în procente mai mici. Da, eu utilizez 585, formula aia de aerosol făcut din soluții de perfuzie.
Mai avem întrebări pentru domnul doctor?
Let me just comment on the team. Social work makes a huge difference. I mean, I'm going to talk on my future talks, but we do annual screening for depression and anxiety, as it was mentioned by the talk, that parents and patients with CF have higher rate of anxiety and depression compared to the general population. So we do the GAD-7 and PHQ-9 that we screen for them. So social work is very important. And then we have the psychologists. Our main team, so it includes either respiratory therapist or a physical therapist, dietitian, social work, nurse coordinator. We also have a transition coordinator, which is a nurse practitioner, because we want to prepare patients and parents to transition from pediatric to adults. In the US, now there are more adults with CF than pediatric patients with CF. And that's what we want in every country, to have adult centers with CF.
Sigur, vă rog.
Totdeauna când stăm de vorbă, realizăm că pentru aspectele complexe, medicii știu ce să prescrie. Dar când încep să prescrie lucruri complexe, privind stilul de viață, ce să mănânci, aspectele de nutriție, ce să faci, ce să eviți, problema oamenilor este că adesea știu ce trebuie să facă, nu știu cum să facă. Acolo este componenta de psihologie. Fiindcă altfel poți să-i spui să facă 1, 2, 3, 4, să nu facă 1, 2, 3, 4, le bifează, dar când te uiți ce face din lucrurile respective, foarte puțin. Fiindcă este o diferență între ce știu, sau ce ar trebui să fac și cum fac acel lucru. Și acolo, de obicei, apare un gap neacoperit de expertiză.
Dacă nu avem întrebări... Da. Ce problemă? E Q&A. Absolut.
I have a question for you, Professor. I was curious more from a almost student point of view. Why do you recommend in New York the genetic testing before the sweat test? And how is that, I don't know, economically better?
That's the newborn screening part that I'm going to talk next time. No, but I'm going to tell you since you asked the question. Because by the time they come to us, we already know whether that patient is malabsorbing or not malabsorbing by their genetic combination. So we're going to start them on enzymes before, because sweat test doesn't tell, before even the fecal elastase come back to me. By knowing the combination of the two variants, then I know that the kid is malabsorbing or not malabsorbing. And also it gives less anxiety for the patient, for the families. Families know that the kid is, by starting the treatment early, the kid is not irritable. Imagine if you had no newborn screening. The parent was going from one doctor to another, the kid was late losing weight, they don't know what the problem is. So you avoid that. Then you bring the newborn screening. Now you have the newborn screening, now you know what the patient has. But in New York, not only you know that patient has CF, you know that the patient, which variant it has. So you can even start the treatment much earlier. It gives rise to other issues that I'm going to talk later, but at least you know everything and you can. And you save money. The studies have shown that you actually save money. Less hospitalizations. I'll give you an example next time, but there is less hospitalizations. So the hospital administration won't be happy because they are not making money out of that hospitalization. But if you have government system that's going to pay for it, they'll be happy.
Sigur, vă rog. Țineți-l la...
Cred că asta ne lipsește nouă. Nu avem studii de health economics. Vorbeam cu domnul profesor, de exemplu, la Mount Sinai, i-am convins să facă o clinică prin care să adauge serviciile de psihologie, tratamentelor oncologice, radioterapie, chimioterapie, chirurgie, după ce am făcut mai multe studii clinice ponderate, în care nu doar că am arătat rezultatul, am arătat că adăugând serviciul psihologic salvezi $1000 per pacient. S-a făcut clinica după aia. Deci trebuie să facem și studii de health economics foarte serioase dacă vrem să convingem autorității.
Sunt foarte greu de convins. Și am să vă dau un exemplu concret. Noi am făcut la Timișoara un studiu relativ limitat, dar l-am făcut vis-a-vis de beneficiul tratamentului de domiciliu. Dar tratamentul la domiciliu al unui copil cu fibroză chistică este o treabă foarte complexă. Necesită personal, necesită tehnologie, dar oricum, în final, rezultatul este mai ieftin, să zic așa, față de spitalizare, pentru că... Nu, categoric. Deci asta este o altă problemă a sistemului medical românesc.
Putem, vă rog, dar doar să știți că după aia avem coffee break și networking. Deci putem face treaba asta toată ziua, dar vă rog.
Numai o completare la administrativ și la ceea ce se întâmplă acum în România. Începând cu anul acesta, au intervenit și Casa va deconta servicii cu 10 puncte pentru consultațiile psihologice și cu 10 puncte pentru kinetoterapie, recuperare medicală și așa mai departe. Toate acestea pot fi adăugate la consultația pe care o face medicul într-un ambulator. Deci, acum cum să vă spun, Ministerul a făcut primul pas legat de cum putem plăti, revine sarcina fiecărui spital să se organizeze, să-și angajeze, pentru că aceste consultații pot fi decontate.
Vă mulțumesc. Dacă nu mai avem întrebări, e cea mai constructivă relația, comunicarea, networking. Dacă nu mai avem întrebări, mulțumim foarte frumos domnului profesor, mulțumim domnului doctor. Vă invit pentru următoarele 25 de minute la coffee break din hall și din sala de lângă. Faceți-vă poze, puneți-le pe rețelele sociale să vadă lumea că e o întâlnire de lucru constructivă. Ne vedem la ora 11 cu domnul profesor. Continuăm. Thank you. Mulțumim foarte mult. După bine meritata pauză de socializare și de cafeluță, vă invităm să vă luați din nou, să vă ocupați locurile. Continuăm până la prânz, până la masa de prânz. Continuăm așadar cu partea a doua a prezentării a domnului dr. Hossein Sadeghi și cu sesiunea de întrebări și răspunsuri. Așadar, faceți-vă confortabil, luați-vă notițele și fiți pregătiți pentru o sesiune interactivă. Dialogul e tot timpul constructiv. Și acum, din nou, pentru următoarea parte a prezentării, îl invit pe domnul dr. Hossein Sadeghi să vină alături de noi și să continuăm prezentarea. Mulțumim foarte mult. Thank you kindly.
Good morning, and thank you again for the organizers. So the topic of this discussion is challenges with diagnosis. So we would like to discuss challenges with diagnosis in the newborn period and challenges with diagnosis in older individuals. So some of the challenges with diagnosis CF in resource-limited countries include challenges in newborn screening for cystic fibrosis, challenges in diagnosis cystic fibrosis, challenges in CF standard management and nutrition and team working. As I understand, CF centers with multidisciplinary team doesn't exist in Romania, but Romania is not alone. It's a lot of resource-limited countries are in the same boat. And also challenges in availability of new therapies. That's something that Romania is overcoming. So this is great. The focus of this talk will be on the first two. So I will start by giving you an example. This is case 1, a 9-year-old female born in Latin America with a diagnosis of asthma. So moved to the United States 3.5 years prior to the initial visit at our center. So she presented with chronic cough despite being treated for asthma, having poor growth, diarrhea, initially presented to the allergy clinic for management of chronic cough. She has been coughing daily since 2 years of age. Cough is productive. The sputum is green in color and can bring up to 1 tablespoon of sputum. There are occasions of post-tussive vomiting in the morning, nighttime cough 3 to 4 nights per week, exercise-induced shortness of breath, frequent visits to the primary care physician because of her symptoms. No systemic steroid was needed in the previous year, and foul-smelling loose stools. So past medical history includes allergic rhinitis, recurrent infection that include pneumonia and pharyngitis, hospitalizations. The last admission was 2 years before presentation, and that was because of pneumonia. Some of the hospitalization required oxygen therapy. The medications at the time of presentation included fluticasone, 110 microgram per spray, 2 sprays twice a day with a spacer. That's aero chamber. I think I saw some of them outside. Albuterol inhaler, 2 sprays 2 times a day with a spacer. She was born full term via cesarean section, no complication, no history of meconium ileus. Her birth weight was about 2.5 pounds, slightly more than 3 kilograms. No exposure to vaping or cigarette smoking, no known drug allergies, no family history of asthma, eczema, allergic rhinitis, cystic fibrosis, or infertility. So initial workup at the allergist office, the immune workup were normal. That include quantitative immunoglobulins, T and B lymphocytes, allergy testing, that's the blood allergy testing, which were negative, ANA, anti-nuclear antibody negative, strep pneumonia titers and tetanus titers were normal. SED rate was slightly elevated. And then genetic tests showed positive for homozygous delta F508, so 2 copies of delta F508 mutation. And at that time it was referred to our center. At the time of initial visit, blood pressure was normal, 104/79, heart rate of 125, respiratory rate was normal, and it was afebrile. Weight was 24 kilograms, so it was 3rd percentile. Height was 133 centimeters, 24th percentile. BMI was less than 3rd percentile. She had digital clubbing, and crackles were scattered on both sides, right side more than the left. And that's the chest X-ray. You can see bilateral interstitial markings. And the lung function, she couldn't perform the lung function really well, but the main purpose was that there was no evidence of change after albuterol. So there was no hyperresponsive airway disease. So we did additional workup. Sweat test came at 103. Hemoglobin A1C was 5.7%. By the way, hemoglobin A1C is not a good measure of diabetes in CF unless it's abnormal. So you need to do oral glucose tolerance test. Fecal elastase was abnormal and shows malabsorption. Liver function test was elevated slightly. AST at 78, ALT 181, that was significantly increased. Gamma GT was normal. Vitamin D was low at 14. Vitamin A was low. CF respiratory culture grew Pseudomonas and methicillin sensitive Staph aureus. Abdominal X-ray showed a lot of stool in the abdomen, and liver ultrasound showed mildly increased echogenicity. So what we did next was, because she was we discontinued all the asthma therapy to start with. Inhaled steroids have no role in cystic fibrosis if there is no diagnosis of asthma. And because of the communication barrier, she spoke Spanish mainly, and she had Medicaid, so she had a state insurance. So in order to expedite all the referrals and all the education, we admitted her to the hospital for IV antibiotics, and the main reason was for education and CF education. So she received 2 weeks of course of IV antibiotics, and during the hospitalization, we gave 4 times a day chest airway clearance, albuterol. At the end of hospitalization, there was slight improvement in lung function, but she had a hard time performing the test. And she started on pancreatic enzymes and vitamin supplementation. And we gave medications, laxative, to improve her constipation. Erstadal was used only for a short period and it was discontinued. Weight, just in a matter of 2 weeks, her weight increased by 2.5 kilograms. And then initially we were planning to start Symdeko because Trikafta wasn't approved for her age group. And then we held it because of elevated liver enzymes. So after discharge, she continued airway clearance and pancreatic enzyme supplementation. After her liver enzymes normalized, we started Symdeko, and then later on it was changed to Trikafta. And this is a nice graph. I love looking at this graph. So just in a matter of less than 2 years, her weight that wasn't even on the graph went above 50th percentile. So this was end of hospitalization, and this was when Symdeko was started. Then the height, she was not that tall. Her height was 25 percentile, but then now she's taller than her mom, and she's taller than her classmates. So talking about self-esteem, her self-esteem improved. Talking about psychological improvement. So when we treat patients, it should be treated as a whole, both physical attention as well as psychological attention. And this is her body mass index. So she wasn't even on the curve when she came. Her BMI now is more than 50th percentile. So that's the importance of having early diagnosis. So the diagnosis, as we mentioned previously, CF can present at any age, at any race or ethnicity. In order to make the diagnosis, you need the clinical presentation plus evidence of CFTR dysfunction or presence of 2 disease-causing mutations in trans. By that, I mean 1 variant should come from mom, 1 variant should come from dad. It shouldn't be both in cis and 1 chromosome. So what are some of the challenges in cystic fibrosis in the newborns. You can have clinical presentation of CF, and then you have sweat chlorides more than 60, or you come down, you detect 2 disease-causing variants. So that's an easy diagnosis. That's cystic fibrosis. End of discussion. You have clinical presentation of CF, then the sweat chloride is normal, less than 29. And you can't find any disease-causing variants. The likelihood of having cystic fibrosis is very low. Then you have to look for other differential diagnoses, whether it's immunodeficiency, primary ciliary dyskinesia, asthma, reflux, chronic aspiration, or Shwachman-Diamond syndrome. So in immunodeficiency, you can have non-CF bronchiectasis. Sweat test is normal. In primary ciliary dyskinesia, you can have sinus disease. Usually middle and lower lobes are affected, versus the CF, that's usually the upper lobe. All the males are infertile due to abnormal sperm. The good thing about CF, the sperm is normal in patients with CF. So the male patients with CF can have kids using in vitro fertilization. And then genetic testing is available for primary ciliary dyskinesia. Again, the sweat test is normal. For asthma, it's reversible airway obstruction, sweat test is normal. Gastroesophageal reflux, you can have, you mainly go by history, pH studies, or endoscopy. Sweat test is normal. Chronic aspiration, again, no malabsorption or sinus disease. Sweat test is normal. Shwachman-Diamond, sweat test is normal. It's a rare genetic disease, but you have bone marrow dysfunction. Now comes an entity. The sweat test is that indeterminate, 30 to 59. If you find 2 disease-causing variants, or you find other abnormality, nasal potential difference, then the diagnosis is cystic fibrosis. If you don't find any CF variants, then the diagnosis of CF is very unlikely. It's less than 1 in a million. How about if you find 1 or no CF causing mutation, then we have an entity called CF screen positive indeterminate diagnosis, or CF SPID. That's the European terminology, which I love. Or the Americans call it CF related metabolic syndrome. And that's an entity we just made up so we can do billing for insurance. So this is the definition. Is the CRMS, is CF-related metabolic syndrome, used mainly in the US and is mainly for healthcare delivery purposes, so-called billing. And then you have CF SPID, which is CF screen positive inconclusive diagnosis, used in Europe. Both terms try to describe an inconclusive diagnosis. And this is one of the difficulties that we face with the newborn screening, because we get variants of unknown clinical significance and then go into that category. So for the parents, we cannot tell them they have CF or they don't have CF, which is frustrating for the parents and actually for us as well, because we can't give them a definite diagnosis. And these patients, the US is coming up with guidelines. We are reviewing our New York newborn screening. We are going to add to these guidelines. Europeans have a guideline that they say these patients should be followed for the first six years and then re-examine them in adolescence and later on. Basically, it's telling us don't let go of these patients, just keep an eye on them. So let's talk about a second case, a 4-year-old female diagnosed during newborn screening. So this, she was born via in vitro fertilization at 37 weeks and 6 days, normal delivery, no delivery complications, birth weight 6.5 pounds, so slightly less than 3 kilograms. So positive newborn screening identified of delta F508 and one variable of unknown clinical significance, G628E, which is 2 reported cases in Northern African population, and that's where the mom is from. Initial sweat chloride in that indeterminate range, 40 and 43. And these parents, highly educated, private insurance, very knowledgeable, they didn't want to come back. They wanted us to tell them, this patient doesn't have CF, and that's the end of story, but we couldn't say that to them. So we keep repeating that sweat test. So the repeat one was 42 and 37. Another repeat one was 27 and 30, and that's when they said, okay, my sweat test is normal, I don't want to come back again. Then we repeated it again, it was 46 and 44, and the latest one was 59. So it's still not 60, but it's almost getting there. We did additional workups, stool elastase was normal, and then the cultures, we were just looking for any pathogens or any clue that sway our decision one way or another. So mainly was growing MSSA, which is methicillin sensitive Staph aureus, but in 2 occasions it grew Acetobacter. So we kept culturing to see if there is any changes. And the chest x-ray, it's not quite normal. So we didn't say it's abnormal or any pneumonia, but it wasn't perfect chest x-ray. And the parents didn't want to do any airway clearance. So this basically summarizes, this is a published data by Dr. Farrell. This is exactly the same protocol that we went through. But the main focus is that by 2 weeks of age, the patient has the diagnosis, and you have some sort of a workup, and the patient has been referred to a CF center for sweat testing by 2 weeks of age. So patient is not going, or the parents is not going from one specialty to another. And it's the same thing that we went through already. And the sweat test still remains the primary test for diagnosis of cystic fibrosis. And to increase the likelihood of collecting and having the results, it should be adequate sample. We usually do it on both arms. The infant needs to be more than 2 kilograms and more than 36 weeks gestation. And each arm is done individually. We don't combine the volumes together. And newborns who are 60 weeks gestation, who meet the above criteria, then it should be done around 10 days of age, or at least more than 1 month of age. One thing that we instruct is that no lotions should be applied to the arm for 24 hours, and the patient needs to be well hydrated. The test should be analyzed within a few hours of collecting it, and it should be reported. Usually we obtain the higher value of the 2 results. Some of the causes of false positive sweat test. So if you have atopic dermatitis, arsenic toxicity, if they are on, this is an anticonvulsive medication, it's in the textbook more than anything else, because if you do it in a newborn, it's unlikely to be on anti-seizure medication. Carbonic anhydrase mutation, glycogen storage type 1, untreated hypothyroidism, and severe malnutrition. So if they have severe malnutrition, you probably need to repeat the sweat test after you correct the malnutrition. This is another challenge with the diagnosis in older age group. So diagnosis of the CF can have different phenotypic presentation. And another challenge is 15% of these patients do not have malabsorption, and they have mild symptoms. So I'll present you the last case. It's a 14-year-old male who moved to the United States 1 year before the initial workup. So he was initially worked up by the ear, nose, throat specialist. And during the workup, as they did different blood work, they found to have liver function abnormalities. And again, these parents were highly educated, affluent, so they went to another center in New York to do evaluation by a hepatologist. Sweat test at the time was 115 and 137, and genetic mutation showed 2 copies of delta F508. The liver shows that he had cirrhosis, he had pancreatic insufficiency, but the kid was smart enough. He was adjusting his diet so he wouldn't have malabsorption or wouldn't be having too many symptoms. And then we diagnosed him with diabetes related to CF because of abnormal oral glucose tolerance test. The 2-hour value was abnormal. So imagine what this kid and family was going through. Was diagnosed with CF, right after that, actually was diagnosed with liver disease. Right after that was diagnosed with CF, and right after that was diagnosed with diabetes, talking about requiring a psychologist. Stool elastase showed malabsorption, and he grew pseudomonas and treated with 1 month of TOBI. So it was getting one bad news after another. And these are his growth chart. So this was his weight, height, this was his weight, and this was his BMI. So they're all suboptimal. Pulmonary function test was great though. 14-year-old, homozygous delta F508, no treatment in his life, and he had a normal lung function test. 98%. So one thing he was doing, he was playing football. And this was his liver enzymes. So he comes to us, his AST and ALT are elevated. 65 and 72. Total bilirubin was okay at 0.3. So there was a whole debate whether to start CFTR modulator or not. Since it wasn't too high, we decided to start the CFTR modulator. And we were expecting the liver enzymes to increase, at least for the first few weeks. To our surprise, it actually stayed the same or actually improved. Then he had a viral infection. And as you can see, the parents were really anxious. It was almost the liver enzymes every few weeks or every few days. And that's because of them being anxious more than us, and they wanted to do the liver enzymes every few days. Then he got a viral infection. The liver enzymes went slightly up, but the liver enzymes are better than when we started on Trikafta. So Trikafta has improvements not only on liver enzymes, not only on lung function, it can improve other organs as well. So we reviewed the first 2 challenges in the newborn screening and in the diagnosis in older age group. Still, there are other challenges that needs to be worked up, and I didn't go into detail to those. One thing I wanted to emphasize, CF is not an individual caregiver. You need a whole teamwork. So this is everyone, this is not even include everyone at our center. These are physicians. We have a transition coordinator, we have a nurse coordinator, We have a nurse and respiratory therapist, dietitian, social work, physical therapist, research coordinator, newborn screening, administrators. I haven't even included the pharmacist, the psychologist, and then the whole series of subspecialists, pediatric GI, endocrine, infectious disease, ENT, genetic counselor, geneticist, lung transplant team, palliative care, and then adult pulmonologist. So it's a whole team that needs to be taking care of a patient with cystic fibrosis. Picture is familiar here. Thank you very much.
Thank you, Professor. Do we switch to the Q&A section, interactive, the one that we were talking about? Stimați invitați, orice întrebări, orice discuții, interacțiune cu domnul doctor, vă rog. Suntem cu microfoanele pregătiți, traducerea e pregătită și mulțumim fetelor. Vă rog.
Mulțumim pentru prezentare. O paranteză înainte de a vă întreba ceva. Să știți că mie și nouă la Timișoara ne place mai mult termenul din Statele Unite, CFTR, Related Metabolic Syndrome. Din prezentare am reținut următorul lucru. Că fibroza chistică are un tablou clinic de prezentare, să spunem, cumva clasic, dar cu simptome care se pot dezvolta și pe parcurs, situații în care diagnosticul poate să fie cumva inconcluziv de la început. Voiam să vă întreb, vis-a-vis de discuția generală cu mutațiilor severe și ușoare, care de fapt, în esență, se adresează doar insuficienței pancreatice. Deci, întrebarea ar fi legată de potențiala intervenție, este o întreagă discuție în momentul acesta, deci de intervenția acestor sau acelor modificatori genetici. Din punctul meu de vedere, va fi următorul prag, sau este următorul prag pe care cercetarea și l-a asumat. Care este punctul nostru de vedere? Avem o speranță în a identifica niște potențiali modificatori genetici vis-a-vis de această discuție largă a relației genotip-fenotip? Mulțumesc!
There is going to be genetic modifiers. That's no question. So that's one thing that it needs to be investigated and needs to be worked at. But that's a process. It's going to take time. But we also have a 6% of population, at least in the U.S., which they have rare disorders, they're rare genetics, and we don't have any treatments. So that's another group that we are not going to leave them behind. And if we go to these other global countries, I have patients who come to me to the States, and their genes are not reported even in the CFTR2. So those are the group that we need to investigate. And for that, there is a study that is a rare disease study, so we do nasal brushing and we do rectal biopsy. The reason for the rectal biopsy is those tissues can be grown indefinitely. And then different drugs can be studied in the lab, and we'll see how they're going to respond. The number of those patients are very few, so we rely on the lab results instead of clinical testing to come up with those results. But that's another question by itself, gene modifiers, but also the 6% of genetic disease that we are working on. I'll give you an example. We had one patient whose older sibling passed away from CF. Part of that was the kid's social situation and the compliance more than anything else. But the younger age group who had that rare disease, we put them in that rare study based on that, actually the older sibling did the rare study, he didn't do it. And based on that, we found out that one variant, N1303K, was responsive to Trikafta. Then we enrolled him into a clinical study, and the younger sibling who had the same mutations enrolled in that study, and we showed clinically that Trikafta improved his lung function. We went to the insurance company. Based on that clinical results, we got approval for Trikafta, and now he's doing better. So, yeah, this is ongoing. But the main thing that's really promising, and one thing that CF Foundation is telling us, we are not going to leave any individual with CF alone. So we're going to work on them, find a cure for any combination of variants or any gene modifying. One thing that's going to come, the gene therapy that CF Foundation has invested a couple of years ago, they just put $500 million just for gene therapy. That's going to take time. There are going to be challenges, because if they develop antibodies, then those are some of the challenges we face. But when gene therapy comes, then that's another venue. One example of gene therapy, the mRNA, is the COVID vaccine. It's mRNA vaccine. So whether we want to use the same technology and apply it to the CF therapy. A lot of people in US are hesitant to get the COVID vaccine, but if you use the same technology, to use it in CF therapy in the future.
Thank you for the presentation. You have one of your patients, the 3-year-old one, who has a normal elastase. I mean, it's 500, and still he was diagnosed by newborn screening. Do you see these cases?
Oh yes.
Yes?
That's the case we were telling about. So that's the case. That's the New York State newborn screening. So that one. So they detect variants of unknown clinical significance, or they have one variant of disease causing. So if that patient screened positive during the newborn screening, then they refer that patient to us for sweat testing. And that sweat test came in that indeterminate range. Even if we had one example of a normal sweat test, but we still didn't let go. The new, actually I think Italian study that came out and says if your sweat test is increasing by 5 points, that could be a marker that may change into CF in the future. So that's one thing we are looking. We have about 125 patients in the state of New York in that CF SPID category. We are working on it, so hopefully we can publish it in the next couple of months. And we'll see the characteristics of those individuals. And one group that we're looking at is CF SPID patients with increasing sweat chloride.
Okay, so by newborn screening we can detect also the pancreatic sufficient patients.
Oh yes, yes.
Okay, thank you.
Hello, I'm a pediatric surgeon. I just have a technical question since, I'm a surgeon. If we have a newborn with a suspicion of cystic fibrosis, the peripheral sample vein is the same test as a blood test from CVS. So you test the child from central venous system or peripheral, because we have a controversy related to that.
The newborn screening?
Yes, newborn for the test.
It's a heel prick. It's peripheral.
Peripheral?
Yes.
So a peripheral is good enough?
Yes.
Since our lab requires a CVS always, and okay, so peripheral is the same. Okay.
For the older age group, we get a buccal sample
Yes.
from their mouth.
We don't do that. Okay.
Exactly.
Just
So all you need is a tissue or a blood sample.
okay. So peripheral vein is enough.
Yes. For newborn screening,
newborn screening,
screening, when we do for the cis and trans, we do the peripheral. We don't do central for anyone.
Okay. Thank you.
You're welcome.
Thank you for your answer.
Am înregistrat să folosiți când aveți nevoie, vă dăm răspuns oficial. I was telling doctor that we recorded this so she can use it as an answer that look, this is what he said. Alte întrebări, altă interacțiune, discuții, lămuriri, clarificări, orice doriți, cu mare drag. That means you were clear enough. That was really good. Dacă nu mai avem alte întrebări, îi mulțumim foarte mult domnului doctor. Thank you so much for your presentation. Thank you for being with us today, traveling all the way.